Good morning, students. Today's topic is periodontal ligament. So, moving on to the introduction. The term periodontium arises from Greek word peri meaning around and odont meaning tooth. Tissues that invest and support the teeth are collectively termed as periodontium. So, periodontium comprises of gingiva, cementum, periodontal ligament, and alveolar. So, definition according to Carenza, the periodontal ligament is a connective tissue that surrounds the root and connects it to the bone. It is continuous with the connective tissue of the gingiva and communicates with the marrow spaces through vascular channel in the bone. And the extent of PDL is in the coronal direction. It is continuous with lamina propria of gingiva and is demarcated by the alveolar crest fibers. At the root apex, it merges with the dental pulp. It ranges in width from 0.15 to 0.38 mm as per AR10K. So the shape of the PDL is thinnest around the middle third of the root with an hourglass appearance, and the ligament appears as a radiolucent area of 0.4 to 1.5 mm between the radioopic lamina dura of the alveolar bone and cementum. So the average width of PDL, depending on the age, is from 0.21 to 0.15 mm. Is on the older you get, and the PDL reduces in its width. And also according to the functional state of the tissues, the times of eruption, it will be 0.1 to 0.5 mm, and hyperfunction will be 0.1 to 0.15 mm. At function, it will be 0.2 to 0.35 mm. And the development of PDL comprises as the root formation continues. Cells in the perifollicular mesenchymal gain their polarity, cellular volume, and become widely separated, and actively synthesize and deposit collagen fibrils and glycoproteins in developing PDL. The type 1 collagen is secreted, assembles as collagen bundles on the bone and cementum surface, and establish continuity across the ligament space. So this is how the development of principal fibers occurs, and as you can see, the alveolar bone proper is seen to the left, and the periodontal ligament is depicted in the center, and the root cementum is seen to the right. This will be the organization of PDL. And the structure of PDL consists of cells and extracellular substances. Cells consist of synthetic cells, resorptive cells, progenitor cells, epithelial rest of malaces, defense cells, and the extracellular substances consist of fibers and your ground substances. Synthetic cells like fibroblast, they are basically used for architect, a builder, and a caretaker. Predominant cells in the PDL, and the origin is from the cementum surface, which is the ectomesenchyme of investing layer of dental papilla and dental follicle, and alveolar bone, perivascular mesenchymal. The fibroblast oriented with their long axis parallel to the direction of collagen fibers, aligned along and between collagen fibers, and appeared governed by surrounding matrix. Fibroblasts of PDL generate an organization pattern as they have certain fibrils from bundles get inserted into tooth and bone and are known as Sharpie's fibers. Once embedded in the wall of alveolars or tooth, these fibers calcify to a certain degree and are associated with evidence of non-collagenous protein found in the bone, which is osteopontin and osteosyloprotein. So, coming to osteoblasts, these cells covers the periodontal surface of the alveolar bone, lines the tooth socket and are cuboidal in shape, and a prominent round nucleus at the basal end of the cell. Mitochondria, RER vesicles are abundant in the active cells. The microfilaments are prominent beneath the cell membrane at secreting surface. Coming to cementoplasts, these cells line the surface of cementum. They are cuboidal with a large vesicular nucleus with one or more nuclei and abundant cytoplasm. All the organelles required for protein synthesis and secretion are present. Cells actively depositing cellular cementum exhibit abundant basophilic cytoplasm and cytoplasmic process. Resorptive cells will be your osteoclasts. These resorb bone and tend to be large and multinucleated, but can also be small and mononuclear. Multinucleated osteoclasts are formed by fusion of precursor cells similar to circulating monocytes. The ruffle border is separated from the rest of plasma membrane by a zone of specialized membrane that is closely applied to the bone, the underlying cytoplasm of which tends to be devoid of organelles and has been called the clear zone. Coming to cementoclasts, the cementum does not remodel. Cementoclasts are not usually found in the ligament. These cells only occur in certain pathological conditions during resorption of deciduous teeth and when regressive forces are applied on tooth, such as orthodontic therapy. These cementoclasts resemble osteoclasts and are located in the depressions in cementum resembling house-shaped lacuna. These cells not only resorb cementum, they can also destroy dentin and enamel as well as they are also called as odontoclasts. The progenitor cells, all connective tissue cells including PDL containing progenitor cells that have the capacity to undergo mitotic division, are the undifferentiated mesenchymal cells that have perivascular location within 5 micrometers of blood vessels. When stimulated appropriately, these cells can undergo mitotic divisions and can differentiate into fibroblast, osteoblast, and cementoblast. epithelial cell rest of Malays was first described by Malays in 1884 and are remnant of epithelium of healthic epithelial root sheet. The pedicle contain epithelial cells that lie about 25 micrometers from the cementum surface. The function is not yet clear, but they could be involved in periodontal repair and regeneration. Coming to defense cells are your mast cells, macrophages, and eosinophils. Your extracellular substance consists of fibers and ground substance. In fibers, they have collagen fiber, elastic fiber, reticular fiber, secondary fibers, indifferent fiber, plexus, and oxytalin. Ground substance consists of proteoglycans and glycoproteins. Coming to collagen, the main types of collagen in PDL are type 1 and type 3 collagen. More than 70% of PDL is type 1 collagen. Type 1 is uniformly distributed in the ligament. Type 3 collagen accounts for about 20% of collagen fibers found in periphery of Sharpie's fibers attachments in the alveolar bone. Type 4 and 7 are associated with epithelial rest of blood vessels. Type 13 collagen is believed to occur within the PDL only when ligament is fully functional. The collagen is gathered to form bundles approximately 5 micrometer in diameter. These bundles are termed as principal fibers. Your principal fiber, PDL fibers, these are very important when it comes to undergraduate level of periodontal ligament. The principal fibers of periodontal ligament given by Holmstrom in 1996. These are collagenous and follow a wavy pattern when viewed in longitudinal section. They are thought to contribute to the regulation of mineralization and to tissue cohesion at sites of increased biomechanical strain. The adult human PDL fibers are 54 to 59 nanometer in diameter. These are your 5 principal fibers of PDL, which is alveolar crest, horizontal group fibers, oblique group fibers, apical group fibers, and interradicular group fibers. And you have your origin and insertion and your supposed function, which can be given clearly in this table. And coming to your Sharpie's fibers, the collagen bundles of the periodontal ligament embedded into cementum and alveolar bone are called Sharpie's fibers. The orientation is similar to adjacent periodontal ligament bundles and are more numerous but smaller at their attachment into cementum than alveolar. Coming to your ground substance is the gel-like matrix synthesized by the fibroblast family and fills the space between the fibers and cells. Its composition of biochemically complex, highly hydrated semi-solid gel and 70% of water. Coming to your blood supply. Blood supply is derived mainly from inferior and superior alveolar arteries to mandibular and maxillar, respectively from 3 sources, which is your apical vessels, transalveolar vessels, and interseptal vessels. Coming to nerve supply, the nerve supplying of PDL is coming to 2 types, which is your sensory and autonomic. So the nerve model divide myelinated fibers, lose a myelin sheet, end in one of the 4 steps of neural terminations. And friendly endings found around the root apex appear dendritic and in terminal expansion among the PDL fibers. Coming to lymphatic drainage, lymph vessels follow the course of blood vessels. Course apically pass through the fundus of socket or they pass through cribriform plate to empty into larger chamber channels posing interosseous functions. Physical function theory, there is specific theories which is formed around the PDL. One is your tension theory, where it states that the principal fibers of PDL are the major factors in supporting the tooth and transmitting the forces to the bone. Coming to viscoelastic theory, according to this, the displacement of tooth is largely controlled by fluid movement, with fibers having only secondary role. And last, your thixotropic theory, where it claims that the PDL has rheologic behavior of thixotropic gel, which is the property of becoming gel when shaken or stirred, then becoming semi-solid again. Coming to other functions of PDL, which is your formative and remodeling function, the cells of PDL participate in formation and desorption of cementum and bone, which occur in physiological tooth movement and accommodation of periodontium to occlusal forces in the repair of injuries. Remodeling, the 3D organization of fiber meshwork is adapted to accommodate for positional changes of the tooth in its socket or changes in functional state. It relates to adaptability of PDL tissues. The PDL is constantly undergoing remodeling. Old cells and fibers are broken down and replaced by new ones, and mitotic activity can be observed in the fibroblast and endothelial cells. Next is your nutritional and homeostatic functions. Adaptability to rapidly changing upright forces and its capacity to maintain its width at constant diameter throughout life. Next is your sensory function due to free nerve endings of any like mechanoreceptors, Mason's capsules, spindle-like pressure and vibration endings. The PDL is abundantly supplied with sensory nerve fibers capable of the repair of transmitting tactile pressure and pain sensation by the trigeminal pathway. Changes in PGL will be increase in collagen fibrosis and decrease in cellularity. An area of ionizations are present. Sporadic mineralization of fibers also occurs. Width of periodontal ligament space also non-functioning teeth is narrower than the functioning teeth. PDL relationship with implants. Implants do not employ ergomorphosis to provide support and attachment to the jaw bones as does the PDL, but still it serves as a replacement for natural teeth. Conclusion: the PDL is a fibrous connective tissue forming important part of periodontium. The PDL is a physically small but functionally important tissues in tooth support, proprioception and regulation of alveolar bone volume. The PDL is an absolute requirement for remodeling of alveolar bone when forces are applied to the teeth. Cell of periodontal ligament are pluripotent and helps in regeneration of all components of periodontium lost in periodontal disease process. A better understanding of cell and molecular biology of developing and regenerating periodontium offers newer avenues to regenerate the PDL. Yet safeguarding the integrity of PDL and alveolar bone is still one of the most important challenges. Thank you.